I am a neonatal nurse practitioner on the unit who is going to perform a head-to-toe examination on baby girl Smith. Before I do so, I would like to just go over the history and review this case. So baby girl Smith is a 12-hour-old, 32-week preterm infant delivered by C-section for worsening maternal preeclampsia. APGARs were 6 and 7, respectively, at the 1 and 5 minute marks. Her birth weight, length, and head circumference are all within normal limits, and this infant is going to be classified as appropriate for gestational age, or AGA. The baby required a brief CPAP stint following admission to the NICU, but has now been weaned to room air and is resting comfortably on the radiant warmer. She's currently NPO, receiving IV fluids at 80 mLs per kilo per day. The infant does remain somewhat hypotonic and still has intermittent episodes of apnea, generally related to a combination of maternal MAG exposure and prematurity. So now that I've reviewed my case study, I'm going to scrub in, wash up, and then I'm going to walk into the room and I'm going to introduce myself to parents, and then I'd like to perform a safety check as well as an equipment check for everything that I need. So I'll walk in, I'm going to sanitize after I've already done my 3-minute scrub in. Hi, are you mom and dad? I'm Vivian. I am the nurse practitioner that's going to be on today taking care of your baby. How are you guys doing? Congratulations on your baby. Do you have a name picked out for her? Oh, Stephanie. Oh, that's so very cute. Baby Stephanie is adorable. If you wouldn't mind, I would love to do a full head-to-toe examination of your baby. And I would love for you to stay and be a part of this examination, and I will go through absolutely all of the steps that I'm doing so that you're aware of what I'm going to be doing with her. First things first, though, now that I've walked into the room, I would just like to check the room for safety equipment and just make sure that everything is where it's supposed to be and that I have all the equipment that I need for this examination. So for my safety checks, I would like to make sure that our suction is hooked up to the wall and it's ready to go. As well, I'd like to make sure that there's a new suction catheter at the end of it, prior to the start of the shift. I want to make sure that my resuscitation equipment is there and available as well. I want to make sure that it's the correct size for this infant, and I want to make sure that that I'm able to turn it on and able to gather it immediately if need be. I also want to make sure that the radiant warmer bed wheels are locked and that your baby is in the correct position, whether that be while you're holding, but I can see that here she's actually lying in bed and she is in the correct position. All the doors are locked to the bed as well, or closed to the bed, and the wheels are locked on the bed. The other thing I note is that she has IV fluids running through her PIV, but that her pump I want to make sure is running at the right rate, and I want to make sure that there's no issues there or that it's reading occluded. So now that I've completed my safety checks, mom and dad, I'd love for you to step over and I can explain to you what I'm going to do. First things first, though, I would like to just make sure that I have, that you all have the correct bands and have the correct identification. So if you wouldn't mind, I'm going to check baby's band while I make sure that I compare the two of yours. Okay, perfect. It's same name and same ID. So, and like I said, I've already done my hand washing, but I will sanitize again now that I have checked my equipment and messed with some other things in the room. So for this exam, I'm going to don clean gloves. Okay. And then I'll make note that if I'm touching anything in the room that is dirty, whether that be a diaper or whether that be just equipment or something outside of the baby's bed, I will be changing my gloves and I will perform hand sanitizing and or hand washing again, just so you guys know, mom and dad. So I also wanted to run through with you really quick just before I start my examination. Have you been a part of rounds yet? If not, please let me explain to you rounds. A, they're very beneficial for you, and B, they're really great for learning as well. So rounds happen with the collaborative team, the interdisciplinary team. So whoever is taking care of your baby at that time. So for you guys, it's going to be the neonatal nurse practitioner team. So we have a group of neonatal nurse practitioners. We'll have a pharmacist, we'll have a dietitian, we'll have the nurse available there, and we will have the attending doctors. And basically rounds is just going through everything that's going on with your baby, in a similar head to toe fashion, but a little bit quicker through each body system. However, we make a plan of care that way. And the really great thing, if you are involved with rounds, is that you are here to advocate for your baby. So if there's something that you might be concerned about or something that you would like to address very specifically with the doctor or the nurse practitioner at that time, you are welcome to join rounds, A, to listen in, and B, to be able to provide your own feedback and any concerns that you may have. And then just so you know, while I'm doing this exam, I'm going to promote the most comfortable environment that I can for baby Stephanie. What I would like to do is start off my exam with doing observation, as we call it. So basically that's just me by a glance looking and seeing if I see anything, abnormal or anything that jumps out at me. The next thing that I'll do is I'll do auscultation with the stethoscope. So I'll listen to a few different areas. And finally, I'll do palpation. And the reason that we do it in this order, Mom and Dad, is because we want to make sure that baby Stephanie is the most comfortable that she can be. And the other thing is too, is while we're listening, it's really difficult, and we understand this, they're babies, it's, they need to be comforted, but it is difficult to listen for heart sounds and for lung sounds if baby is crying or if baby's uncomfortable. So we like to go through and do the most comfortable sort of to the least comfortable. But when we get to the least comfortable portion of this, and we start to mess with her a little bit more and we start to do more palpation, I'll have you, and you're very welcome to please come and stand by me while I do the full exam. But while I'm doing the palpation, I recommend and encourage you to do some containment exercises with baby Stephanie. So I want to make sure that also for her comfort level, the room is at a comfortable temperature in here, that it's not too cold in here. We like to keep these rooms, warmer, but comfortable. And the other thing is I want to make sure that since she's on a radiant warmer, I want to make sure that her temperature probe is connected and that actually I'm seeing that, the bed is reading a comfortable temperature and it is heating and or cooling her as need be. So for my first part of my general assessment, as I said, I'm going to just sort of be observing things. So the first thing that I'm noting is that your baby is lying here supine, and she seems to be resting very comfortably. So, she had started off on CPAP, so I don't see anything right now that suggests to me that she's having any respiratory distress or that she is uncomfortable in any means. Whether that be crying or whether that be any obvious work of breathing. So as I'm noting, I don't note any nasal flaring, which would be sort of the opening of her nostrils really wide. I don't notice any grunting, which is just sort of a sound that babies tend to make when they are experiencing respiratory distress. Sometimes, Mom and Dad, that can be confused as baby sort of whining. But a lot of times we sort of can tell if that's actually a sign of respiratory distress. And right now I don't see that, nor do I hear it. And the last thing is I don't see any tracheal tugging. So I can see that she's not having any increased work of breathing, just lying here supine. And then the next thing I want to note while I'm observing her like this is her tone. So of course right now it seems that she's resting comfortably. When I first walked into the room and when I walked over to the radiant warmer, I did notice that she did have some movement. So she is responsive to sound and she's responsive to stimuli, but probably her tone is still a little bit low because, Mom, you were on that medication called magnesium. It's a very, very normal response to magnesium for an infant to have sort of lower tone, which means that they're not going to be moving around as much on their own unless we're stimulating. And the other thing is too, is that's probably why she needed to be on CPAP initially, is because magnesium also causes respiratory depression in infants. So all that aside, just to explain to you what magnesium can affect. All that aside, she does have somewhat lower tone while I look at her now, but she's also resting comfortably, so I'm not too concerned about her right now. And then I just wanted to let you know that the head to toe, just letting you know everything about what is examined. I mentioned to you we're going to do observation, we're going to do auscultation, and then we'll palpate. But we are literally going to go head to toe. So we are going to start with the head and we are going to end all the way at the bottom, as well checking the backside. And so, like I said, I really would love, if you are comfortable and if you would like, for you to join me here at the bedside and to perform some containment where it's needed, which I can indicate to you when we might need that. And then additionally, to just see everything and hear everything that I'm doing. So the other thing that I'm going to look at now that I'm observing her like this without messing with her at all is any sort of obvious malformations or deformities, which I don't see right now. And she definitely doesn't have a pacifier. So I see that she does not have any cleft lip. That's something that I'm noting that she doesn't have as a malformation. Some other things I'm noting that she has a symmetrical looking body, and she also does not have any unequal limbs or any other malformations that are really jumping out at me at this time before I get very detailed into looking. The next thing I wanted to assess is just by looking at her, she is, of course, just in a diaper right now because she's under the radiant warmer. Should she be in a bassinet or in a crib at some point, we will definitely start to do more swaddling. But right now, because she's 32 weeks and we want to promote thermoregulation and normal temperatures, we have her totally fine in a diaper here, and the bed is warming her. So anyhow, all that to say that I can see right now that she does have a little bit of lack of subcutaneous fat around the anterior thigh, which we do expect for her as a premature infant. This is going to be fixed with her total fluid goals that we're going to continue to meet. So currently she's NPO, which means nothing by mouth, so we're not doing any breastfeeds or bottle feeds right now. What she will eventually be getting is enteral feeds, which will be through her NG or her OG tube, and that can always be, whatever you and dad want, if that's breast milk or if that's formula, it's entirely up to you. But as for right now, the way that she's getting her nutrition is through her IV fluids. So that's how we're going to assure that she is still gaining weight adequately and that she's still getting fluids and electrolytes that she needs. The next thing that I want to see, or the next thing that I note based on how she looks right now and based on the history that I have, is that she is what we call appropriate for gestational age, mom and dad. So that just means that her weight was assessed, her head circumference was assessed, and her length was assessed. And all of those are symmetrical with one another. So while she is small because she is premature, all of her measurements, however, are appropriate for the 32-week mark. So she is an AGA, or like I said, appropriate for gestational age infant, based on what I'm seeing. And then the next thing that I'm noting here too is that her umbilical cord looks appropriate. It's the nice pearl white color, and it has just a little bit of the Wharton's jelly still. It is starting to dry up now, so I don't see too much left over, but just by looking, this is what I see. So the first thing that I'm going to do before I even start to auscultate it is I'm just going to assess her respiratory rate just by kind of looking at her, her respiratory status. So what I'm noting is that she has irregular respirations, mom and dad, and that is totally normal. We expect that. Even for a term infant, we do expect for them to have abnormal respirations. Now, what we're not wanting is for them to be to have too high of respirations or too low of respirations. And right now it does not seem either way, but that is just something that we are assessing initially. So now that I have done like a pretty good look over, just observation, of course we will get more detailed here in a moment, but now that I've done my just observation, I'm going to start by auscultating. So for auscultation, I'm going to be listening to a variety of different sounds. I'm going to listen to lung sounds, I'm going to listen to heart sounds, and I'm also going to listen to abdominal sounds. And at the end of that, I'm going to listen to her anterior fontanelle, which is at the top of her head. So I'm going to start listening with lung sounds, and I'm listening here. And I'll listen in all four quadrants up front. And by all four quadrants, in terms of respiratory, we're listening to the upper portion of her body and we're listening to the bases of her lung sounds. The other thing is I want to listen under both axilla. Perfect. Okay. So when I listen on the front, I'm listening between the third and fourth intercostal space. mid-clavicular, so that means below the clavicles and the midline. And when I'm listening axillary, I'm listening between the 7th and 8th intercostal space, which is lower down between the ribs. Okay, mom and dad? Okay, so what I'm hearing for her lung sounds is she sounds nice and clear. There's good aeration, meaning there's good air movement through her lungs. And I've just touched my face now, so I'm going to change my gloves. So I hear good aeration, which means she's moving air just fine. And I don't hear any adventitious breath sounds. So I'm not hearing any like gurgling, or not gurgling sounds, but any wet sounding lungs, which we call rales. I don't hear any rhonchi, which is sort of crunchy sounding lungs. So she sounds nice and clear. Now I'm going to count her respirations for a full minute. Okay, and after listening for that full minute, I do hear that she has 56 breaths per minute based on my listening for that full minute. The next thing that I'm going to do is I'm going to listen for heart sounds. So I hear a strong S1 and S2. I do hear a soft murmur. And just really quick before I continue on, Mom and Dad, I just want to let you know that a murmur is a pretty common finding. It's sort of a whirring sound that we hear, not worrying, but whirring type sound that we hear in the heart, and it is very common for a premature infant to present with a murmur. Now, a murmur we're not too worried about right now. We will monitor very, very closely, and it will be providers as well as the nurses at the bedside that are going to be listening and assessing all the time, and we'll continue to monitor for now. If any intervention would be needed, the next step would be a cardiac echo. But for right now, we are okay with the presence of that murmur. So other than that, if I count for heart or for beats per minute for the heart, okay, and I listen for a minute and I hear 158 beats per minute. So Mom and Dad, that's very normal for Stephanie's age and for her gestational age and her size and everything. We expect about 156, that's normal. 158, I'm sorry. The next thing I'm going to do is I'm going to listen over her belly. And I'm noting that she's starting to stir a little bit more now that I've been messing with her, but she's still comfortable. So I'm listening for her bowel sounds. And this is something too that we're going to listen in all 4 quadrants. Okay, and so I'm noting that her bowel sounds are a little bit what we call hypoactive, which means that she's just not, they're just not quite as loud. I do hear them, so that's a reassuring sign, but they're just not quite as loud as they might be once she starts feeds. But when she does start feeds, which hopefully will be soon, we anticipate hearing them a little bit louder and louder because she'll have things finally starting to move through. The other thing is with that magnesium that you were on, Mom, it is not impossible for bowel movement and bowel pattern to be just a little bit decreased for right now. And then the last place that I'm going to listen is over the anterior fontanelle. Okay. And I'm here checking for a bruit, and I don't appreciate one. Okay. So that is the auscultation portion of my exam. So now, Mom and Dad, this is the part that's a little bit more hands-on. So if you note that she starts to stir or that she starts to get a little bit more irritable, that's totally normal. We do expect that, and then we can show you how to do some containment with her. So first things first, I'm going to check her point of maximal intensity, or as we call it, PMI, and this is right over the 4th intercostal space, and this is a really great place to be able to check, the strongest place really to be able to check for pulses. So we'll feel over the heart. The next place that I'm going to feel is her femoral pulses. And we like to do this also for the time being because she's still relatively calm. And this is a little bit more difficult to assess when baby is crying or moving a lot more. So I'm feeling for her femoral pulses right now. They feel equal, they feel strong on both sides. And we would mark this as +2, mom and dad. So that's how we would classify her pulses right now. And then I'll just continue to move down. So I'm going to check her posterior tibial pulses, which is behind the back of the knee here. Same, I'm feeling equal, strong, and +2. I'm also going to check pedal pulses, and this is on top of her feet bilaterally. So I'll check right, and then I'll check left. I'll check together, and it feels like they're equal, strong, and I would mark them as +2 also. So now moving back up, I'm going to start at her brachial pulses. So this is here on the inside of the upper arms. +2, they feel equal, they feel strong. We'll move down to radial. +2, equal and strong. And then we can do palmar pulses as well. Perfect, they're +2, they're strong, they're equal. Okay. Now, to go through the rest of my, or to start with the rest of my physical assessment here, or the palpation part of the assessment, and the whole rest of the assessment, I'm going to start with the skin, just generally. So to me, she appears nice and pink, warm. When I was checking her pulses, I noted on her fingers she has good cap refill in her nail beds. So that's less than 2 seconds. And cap refill, mom and dad, is when we're checking just to make sure that the blood is refilling really nicely. So when I press here on her little fingernails, they do fill back up in less than 2 seconds. The next thing that I'm checking for is her mucosal membrane. So this is sort of here what I'm seeing. So that just means that on the inside of her mouth, she's nice and moist and pink on the inside as well. No paleness, no dryness. She can be dry throughout, which is normal. We don't want her to be sweating or moist or anything, but the inside of her mouth, we would like for it to be moist. So it looks like her mucosal membranes are nice and moist and pink. Her skin color is appropriate for her ethnicity. She does not appear with any outward skin abnormalities such as hemangiomas. I don't note any milia on her. I do see over her left eyelid here, she does have what you, mom and dad, might know as a stork bite. We call it a nevus simplex. Very, very normal. Something also that we'll just monitor, but it should be gone, honestly, in the first few months of life. Sometimes it tends to disappear. So the other thing, just to look through skin, I'm not noting any skin tags, any obvious skin tags on her ears or anywhere else on her body right now. She does not appear to have any lesions or any rashes when I look through her skin here. So, and she has what we call good skin turgor. So it looks as though she's not dehydrated. Her skin has a nice elasticity to it. So that's what we're looking at when we assess skin turgor. I'm not noticing any jaundice on her as well. So that could develop over time. It's very common for premature infants, but at the time, as of right now, I don't see any obvious signs of jaundice, which is that yellowing of the skin. She does not have any acrocyanosis, which means that she has her feet and hands, her extremities are not blue. She's nice and pink all throughout. Her skin is nice and smooth upon palpation. I do not note any injuries, any lacerations or anything from delivery or any other really big birth injuries. I do note a little bit of, I understand that you noted that there was an injury from birth. If you'd like to show it to me. Oh, okay, here I see on the calf. Yeah, it looks like, so that was there right at birth. And I did see in the delivery note that was noted as well. So we'll just keep an eye on this for right now. We're okay with it. But she does have a small bruise on her calf from delivery, it would seem. And then the last thing I want to check when I'm checking her skin right now is that I want to make sure that where her IV is running, her PIV in her left hand, I want to make sure that it's nice and pink in that area, but that it's not, there's no redness to it. It's not warm to the touch, and it doesn't appear swollen or to have any discharge or any yellow or white discharge coming out of it. So The IV looks great. So now I'm going to start from her head and work my way down. So her head feels nice and rounded. It does feel symmetrical. I'm going to palpate her sutures here. So I'm noting that her anterior and posterior, that her cranial sutures are separated and they are mobile. And that is both her cranial and her sagittal sutures. I'm also feeling for the fontanelles here, and her anterior fontanelle appears to be, or feels soft and flat, and it does feel mobile. And then I'm going to check the posterior fontanelle here, and that also appears to be soft and flat and mobile. Okay. I am not noting any caput, and I'm also not noting any cephalohematoma or any other bogginess to the head, which we would expect with a birth injury, with a vacuum type delivery or anything. But mom and dad, I'm not noting any injury to the top of the head here. I'm also not noting any molding to her scalp, which usually is noted in, more so it's noted in vaginal deliveries, but it's when the head is sort of misshapen from being in the birth canal or from coming out of the birth canal. So, but I'm not noting any molding as well. Her hair pattern seems normal. I don't notice any worries there. I don't notice any other scalp defects. I'm not noticing any lesions or protuberances, no abrasions or contusions to the head. And we previously listened for the anterior fontanelles to make sure that there was no bruit. So I'm going to move over to her face. So here I'm examining pretty much everything on her face, including her eyes, her ears, her nose, her mouth. So for her eyes, to start with her face, she has a rounded face. It's symmetrical, and it seems like it's moving equally bilaterally, meaning on both sides. Her eyes are opening spontaneously. They appear to be normal and in the correct position. Her pupils are round and of equal size, and it seems that they are reactive to light. If I use here my light here, perfect, okay. Equal and reactive to light. She does appear to have dark blue irises with white sclera in both eyes. I am not noting any conjunctival hemorrhages or any nystagmus or strabismus. Her outer canthus is higher than the inner canthus, which is the normal positioning that we expect of the eye. I do not note any eyelid drooping. The length of her eyebrows appear to be the same. And like I said, I just noted that nevus simplex, or that little stork bite to the left eyelid. So no worries there. The next thing I'm going to do is I'm going to check for her, I'm going to check with an ophthalmoscope just to make sure that the red reflex is there. So I'm going to hold this far away. Yep, we have a red reflex there. Perfect. Okay. The next thing I'm going to do is I'm going to inspect the ears. So they seem to be in the normal position on both sides. They are developed and formed normally, so both with the helix tragus and the lobule. The pinnae, which is the sides of the ears here, are soft with good recoil and well-developed cartilage. Her ear canals appear patent. I do see a small amount of vernix in both of her ear canals, but they do seem that they are patent. She does not present with any pre-auricular pits, no dimples, no sinuses, and I don't see any skin tags noted on her ears. The next thing I'm going to check is I'm going to move down to her nose. And so for her nose, I do see that it's vertical and it's in the midline position. So it is positioned appropriately. She does have bilateral nares present, meaning the openings of her nose are both there. And I don't see that they would be blocked with anything. I don't see any discharge or any running of the nose. They appear to be patent. I don't note any septal deviation when I look. And she does not appear to, or she does not sound like she's very congested. I don't hear any stuffiness. The other thing is, too, is I'm not noting any nasal flaring, which I had sort of mentioned previously, which is a sign of respiratory distress. Next, I'm going to move down to her mouth and her throat. For her mouth, I see that her mouth is positioned appropriately between her nose and her lips. Between the philtrum is noted between her nose and her lips, which is this little line here, right between the two. She has, her upper lip is nice and smooth, nice and pink. Like I said previously, her mucosal membranes appear to be moist, pink, and intact. And then I'm going to actually check the inner part of her mouth because I want to check for her palate. So I just want to make sure. So obviously she's not presenting with any cleft lip, but I just want to check to make sure that she doesn't have cleft palate either and that her palate is in fact intact. So I'm going to stick my little finger into her mouth. Perfect. Her palate is intact. It feels normal. And actually, I'm noting that she has a very good suck reflex. She's kind of starting to suck on my finger. While I'm doing this, I'm also noting that she has no natal teeth, which is just the presence, mom and dad, of baby teeth really at delivery or at birth. And I don't note any Epstein pearls either. Now that I know that she actually has a good suck reflex, this might actually be able to help calm her a little bit and help settle her while we do the rest of the exam. We'll give her her pacifier. And then I want to assess the trachea. I want to make sure that it's midline, and it does look like it's midline. It's in the appropriate position. I'm also going to check her neck for any abnormalities, but her neck feels nice and soft. No palpable masses that I can feel. No thickness to the back of the neck, so it's normal. I don't feel any swollen lymph nodes. I just want to check range of motion. So this is actually known as the fencing reflex here. So it's sort of range of motion of the neck. So I would ideally turn her head to one side and then be able to turn her head to the other side. And it's just showing to me that she has full range of motion of her neck. And then I don't see any signs of torticollis or, like I mentioned, that excessive skin, no webbing to the back of the neck, and no palsies. So now I'm going to move down to her chest. And so for the chest assessment, we've already done our auscultation portion of it, which is where we were listening to breath sounds, we were listening to heart sounds. So the first thing that I note on her chest is that she appears to be symmetrical. There's no abnormal movement, so no seesaw respirations or paradoxical movement, which would be indicative of some sort of traumatic injury to the chest. And basically it just means, mom and dad, that it's just the chest wall is literally moving at different times. So right now I'm not seeing that. Her chest is nice and symmetrical. Her anterior and posterior diameter is equal to her transverse diameter. And actually I have my measuring tape here so we can measure. Oh, perfect. Okay, looks good. The next thing is I note that she has 2 breast buds. They're nice and pink. They are symmetrically placed on her chest, and she does not have any discharge from them. I also am noting while I'm looking at her chest movement that she is not showing me any signs of retractions or any increased work of breathing in her chest. And her chest movement is symmetrical with her abdominal movement as well. So both move symmetrically. The next thing that I want to check is her cardiovascular stability. So we went through listening to heart sounds, and we also went through all of the pulses earlier. So the last thing that I just want to mention to you, since we've listened to all of her, or we have listened and we've felt all the pulses and they feel nice and strong and they feel appropriate, and we have categorized them as +2, I just want to let you know that we would do extremity blood pressures on all 4 extremities just to make sure that they are all matching and they're appropriate, because it could be indicative of a sign of a cardiac defect if we're getting different readings on her upper extremities versus her lower extremities. So that's just something that we'll check. But for right now, just for other things cardiovascular wise, we did check capillary refill. That looked fine, or it looked normal rather. She does not present with any obvious edema to her body, and I'm not noting any modeling to her body either. We listened for her heart sounds, and we listened for her pulse. We did auscultate that murmur, but no additional heart sounds outside of that. So now we'll move down to her abdomen. So the first things first that I want to check with the umbilical cord is actually that it is starting to dry, but I'm noting that there are 3 vessels. So we always check that right at delivery, but I do see that she has a 3-vessel cord here as well. It is still very, very slightly moist. The cord clamp is still on and it's in position, but it is starting to dry. Her abdomen is noted to be nice and flat and smooth and soft, nice and pink. And like I said, it moves symmetrically with her chest movement. We auscultated her abdominal sounds earlier, and we did know that they were slightly hypoactive. I'm not seeing any signs of distension. It's nice and flat. And I don't see any bowel loops. And mom and dad, that just describes when there might be some air in the belly, and it literally looks like little loops in her belly. So I'm not seeing that right now either. No discoloration. And then the last thing that I want to do is palpate the different organs here. So I'm going to palpate here about 1 centimeter below the right costal margin for the liver. And it feels normal here. And then I'm going to come to the other side for the spleen. I feel that as well. And then we're going to palpate for the kidneys. And so for the kidneys, what we're going to do is we're just going to slide one hand underneath, and we're going to kind of gently put some pressure here on the front so that I can feel it to the back, and I do feel it's in the appropriate position. They're smooth and firm. We're also just going to palpate a little bit with a little bit of pressure here to make sure that the bladder is in the correct location. It seems to be normal. Perfect. Okay. Finally, the last thing is that I don't note any omphalocele, which is the abdominal contents starting to come through the umbilical cord. I don't see any omphalocele, and I don't see any omphalitis, which would be indicative of an infection near where the umbilical cord is. So neither of those. So now moving down, we're going to check her external genitalia, mom and dad. So for a preterm infant like her, I would suspect that she has a slightly prominent clitoris, which she does, but she does have present labia minora and labia majora here. I can see that her urinary meatus is present, or her urethral meatus is present, and I don't note any skin tags or any abnormalities here to the vagina. Actually, while I'm doing this, I also would just like to check for anal patency. So since I have her diaper open, I do see that she has anal patency, and actually it looks like she's had a stool prior to this, so patent at this time. The other thing is that her diaper is notable for yellow colored urine, so I'm not worried about what her urine output or color looks like right now. No vaginal bleeding or discharge noted as well. Now we can move down to her musculoskeletal system. So first things first, I would like to make sure that while she is lying on her back, we have done our full check, but now I'm going to place her prone actually. And we'll do this by gently flipping her, and we'll move her head to the side. And I just want to check for the back of her, her spine. I want to make sure that there's symmetry noted there. There's no asymmetry. I'm not noticing any tufts of hair, and I'm not noticing any dimples. And actually, now that I've turned her over too, I can check for any skin abnormalities. So I'm not noticing any lesions or rashes, and I don't notice a Mongolian spot either. So not that we would suspect, but we are just checking for all of the things on the back. She is noted to actually, now that she's moving around a little bit more, I'm noticing that she has some passive and active some passive and active movement in both her upper and her lower extremities. I do want to check for full range of motion up here in her upper extremities. Okay. Perfect. Okay. And then some more range of motion. We're going to do what's called the Barlow and Ortolani maneuver. So I'm going to bring her knees together and adduct, meaning bring to the body, her knees flexed. And then I don't feel any dislocation or popping or clunks in her hips. And then we're going to bring them back out to do the Ortolani maneuver. And I don't feel any dislocation there either. The next thing that I want to check is that she has we've checked spontaneous movement. I do want to check to make sure, now that I'm taking a closer look at her, that she does not present with any syndactyly or polydactyly. So syndactyly is the webbing of the fingers and the toes, and polydactyly means that she has an extra digit or two. So mom and dad, I'm not noting any of that. She has 10 fingers and she has 10 toes. So we're happy with that. I do note that she has palmar creases, but she does not have one single palmar crease. And her plantar creases are noted as well. I am just going to check for a Babinski response. Okay. And while I'm checking with her hands too, I want to check to make sure that she has a palmar grasp, and she does. She's holding onto my fingers. And then just some other things that we can check here while we go through our reflexes. So we've already checked our root and suck reflex earlier, which is how she's able to hold on to the pacifier with the suck reflex. The root, she sort of sucked on my finger, but outside of that wasn't really showing any signs of rooting. And then the palmar grasp is good. We did check the fencing reflex earlier, and we've just checked the Babinski. So now we're going to check the Moro, which is the startle reflex. So I'm going to just kind of like lift her arms here and see if okay, perfect. She does startle. Okay, and then the last reflex that we can check is called the stepping reflex. So I am just going to like hold her up here for a second. And the stepping just makes sure that she actually wants to like put her foot on something or press with her foot. So it looks like she does have the positive stepping motion. Perfect. She does not note, I don't note any skeletal anomalies on her, and I don't note any tremors, brachial palsy, or seizure activity with her. Finally, just for an end neurologic examination. So she is a preterm infant, and she is AGA. She noted to have woken up not spontaneously, but more so with stimulation, sound stimulation, as well as painful stimulation, which is not necessarily pain inducing, but it's just sort of palpation and messing with the baby. So her tone is a little bit still low, but mom and dad, as we discussed, that has to do with the magnesium medication that you were on. So we expect that that's normal. She does, however, respond to voice. And so let's check her ability to follow here. Let's see if she sort of follows and fixes on an item. Okay, very slightly. And then finally, I just want to make sure that she does not have any other neurological deficits, which she does not. Not that she had any initially, but it would seem as though she enjoys to be in the flexed posture. So this is something that you can do with containment. That seems to be her position of comfort here. She didn't really have brisk movements, range of motion. However, she does have that range of motion. And as the mag starts to wear off more and more, she will start to show more appropriate signs. Other than that, that really concludes our head to toe assessment. So is there anything else that you can, or is there anything that you can think of that you might have for questions, or any specific things that you would like us to monitor outside of what we already kind of at baseline monitor? If not, I would love to encourage you to please call me back to the bedside if you need anything, and I am happy to answer your questions. Otherwise, it was so very nice to meet you both, and we will take great care of Stephanie.